couple of goals that we had with this session. I really appreciate you inviting me. Sorry for the egregious detail on all the things we do. I know all of us in all our jobs wear a million hats, similarly. But for me, the goal was certainly to, introduce you to the program. Happy to answer any questions you have. If you want to stop me at any point during the talk. I also really welcome you to put in the screen, in the chat, any questions you have going into this, and maybe really quick, like your role. So one thing that Dementia Care Aware really does is we try to train primary care. That's really our goal on dementia screening and a dementia screening approach. I have a feeling you guys are all really, really, way beyond needing to learn about screening. So I was going to kind of walk you through what we're teaching folks. I think one of the reasons for that is to, honestly get your thoughts and to get your partnership around what we could do better. Does this sound like something you would want your primary care colleagues or generalist colleagues to engage with or promote the program, or, your thoughts and ideas? Because I know you guys are steeped in the work around dementia. So just, feel free to rein me in and ask the questions that that really interest you and take it in different directions. So I'll tell you a little bit about the program. It's kind of my general plan today, and then kind of show you what the cognitive health assessment is and what we're teaching primary care, hoping and assuming that interests you somewhat. And want to point out there is a section that we typically do to review with everybody, kind of get on the same page about what is dementia, what are we even talking about? Because to be honest, that understanding is not necessarily solid or very clear. It is something that a condition that seems to confuse everyone around it. So, but I didn't think we needed to go through how we talk about what dementia is with our other learners. So I'm going to skip that part, but if you want me to go back and address that, happy to kind of show you how we talk about it, how we teach it. Again, I think for you guys, maybe one of the goals is to see how we're teaching this approach, get your thoughts on it. And so I'm going to basically be, I think, speaking at sort of a meta level through part of this, showing you kind of a show and tell of how we teach folks. And again, just so welcome your input and chat throughout. You're also going to see a whole bunch of links. The reason for the links is Medi-Cal. This is a very short effort on the part of Medi-Cal to get training out there. And as a goal to be good stewards of the resources that they've put towards this, we basically have to take attendance and then to give you CE at the end. If you want any continuing education or continuing medical education credits, we have to surveys. So hopefully it feels worth the effort to just let us know that you joined us with the attendance survey and then do the continuing education credits surveys at the end. But I do apologize in advance for what probably seems like way too many surveys. So you heard a little bit about me. I think the thing to just know there is I did primary care that's sort of my first love clinically, really enjoy it. But was also doing a lot of GRE consult stuff on the side and realizing that dementia was really what my primary care colleagues seemed to want to refer to me for. It didn't seem like they were quite as overwhelmed or maybe even aware of some of the other geriatric syndromes, which is okay. There's clearly work to be done on the proactive healthcare side for geriatric stuff. But to be a good colleague and a good consultant, I really just kept doing more and more dementia, which is how I ended up being more engaged with dementia work and got the opportunity to run this program. A little background on the program. So the cognitive health assessment is what we call the screening approach that we promote all over the place. So Dementia Care Aware is the program. The cognitive health assessment is a screening approach that we promote, and say, like, use this in primary care. So that's kind of the two pieces of that. And our funding started in March 2022, and it's going to end the end of September this year. So 2.5 years to realize a statewide program to train primary care to do screening. So that was kind of the what we're working with there. Just for CE purposes, no financial disclosures. I mentioned already the CE/CME stuff will come at the end. You'll have a chance to register if you want to get that credit. This is worth 1 credit. And then what we're going to again talk about is I'm going to walk you through the learning that we put out there, and the main chunks for you to be aware of are, we kind of review with people why it's important to screen. So we start with the why. The other is we review this cognitive health assessment approach and screening tool. I actually try to avoid us calling it a screening tool, but my bad there, leaving it in the agenda. But and then we talk about what resources are out there for people to get more support in terms of implementation. I'm going to actually reverse that a little bit for you guys and talk a little bit more about the program in depth, and then we'll talk about the CHA. So our program, like I said, new program, we want people to screen in primary care. This is statewide. We have a focus on Medi-Cal patients because DHCS is Medi-Cal. So that was sort of our lens. Why did they decide to do this? In case you don't know, I think actually always possible you guys were somehow involved as advocates, but essentially one of the state senators with colleagues, made it their mission to ensure that, one of the efforts to ensure that people with dementia are recognized and access care was Senator Limon, and she put forward a bill that would legislate the necessity to have a screening benefit available to Medi-Cal only people or beneficiaries that are older. So what does that mean? In Medicare, we have opportunities to screen and bill for that through the annual wellness visit or other mechanisms. In Medi-Cal, there are some people in our state who have Medi-Cal and not Medicare and are over 65. Not to get too in the weeds, but Medi-Cal is a huge population of people in this state. And so even if it's a small percentage of Medi-Cal beneficiaries who are 65 and older don't also have Medicare, it's still a large number because we're California, and that's just the way that's how we roll. Everything is bigger. So, there's like 250,000 people in the state who are older and have Medi-Cal, meaning they're low income, but don't have Medicare, meaning they didn't pay Medicare taxes or they didn't work in the country for enough period of time to qualify for Medicare. So for those folks, this law said, okay, well, now they have access to this screening benefit. And you may or may not, feel super connected to policy. The thing about, opening up a screening benefit does not necessarily mean doctors, healthcare teams are like rushing to provide care. Then there's this whole other process by which they need to be made aware that this benefit is available. And if they use it, they can, the clinic can bill for it and all that. So anyway, the way things get implemented is something I have since learned a lot about. So what did we need to do? We're like, okay, great. We get to encourage screening. I'm very passionate about it. But the core of it is, here's the other thing. The legislation said, not only is there now a benefit to screen, the people who do the screening have to be trained, and we have to have a record that they did a training. Why? Because we all know that generalists, specialists, everyone is catching up. Nobody knows anything about dementia. They need more training. Nobody's doing it right. So they need that support. It's not an indictment of their skills. It's just they need that support. So we had to create not only, actually our first project really was to create the training, decide what the assessment approach was going to be, what tools we would use, because the law also said it had to include validated tools. and then create a training. All of that had to be available by July. So we convened a bunch of state and national experts to decide what goes into the screening approach. We developed this training with, educational experts and, really skilled online learning folks. And then we rolled it out starting in July. Okay. So then we also said, we got a lot of resources to do this. So the other thing we wanted to do is add additional training to the mix. So not only a core training on the cognitive health assessment, but additional topics to support implementation. How do I do it if I don't speak the same language? How do I do it if the person, is really challenged around hearing? How do I do it if they have a developmental disability or an intellectual disability at baseline? All the questions that come up in like your standard day-to-day clinical practice. The other thing we did is start monthly webinars for updates, just, topics. So we have those going on all the time. We also started a podcast because entirely perhaps a personal decision on my front. I do a lot of learning on podcasts as I'm, multitasking, as they say. You're really monotasking in an efficient manner, but still. So we just wanted to give busy providers many ways to get the content and the learning. And then everything has CE, CME all over it to make sure there's at least that piece for people, because it's really important to maximize people's time. Then we had to create a statewide outreach effort. So we have a bunch of partners on that. Alzheimer's Association and local Alzheimer's organizations across the state have been really key partners to outreach. I mean very sincerely outreach, like cold calls, emails, letters, like you would not believe. Then we also go to a lot of events and try to get, nurse practitioner conferences, internal medicine, family medicine conferences, all the places we try to go and let people know that we're a resource for them. And then we had a media campaign and continue to do social media to get the word out. We also had a health systems implementation arm. So this has been a really interesting learning for me, but basically, how do we support primary care clinics? Essentially, mostly that's who we're dealing with, to do the implementation. So we have literal hands-on coaches that can work with your clinic to create a workflow, to train people to figure out how you're going to do this. Then we have things like ECHO conferences where people will do case-based learning over time as a cohort. So they basically use the tools in real life and get feedback in real time about how that's going, and everybody learns. We have a website with a lot of practice resources, and we're finishing up essentially an implementation toolkit. Everybody loves a toolkit. And then we have a warm line. So 9 to 5, Monday through Friday, there is a platform that we have that's online that people can call in, and we can engage with them over the platform and email them resources and answer their clinical questions about dementia care. And of course, we don't limit it to screening, although we promote, we'd love to help you with the screening issue, but if you have another dementia clinical question, we're here for it. The other piece is evaluation. So we're in the process of tracking everything we're doing, how many people we're training, what are they doing, and we have several implementation sites that are implementing this screening approach and tracking what happens with those patients and doing a both quantitative and qualitative evaluation of the success of the program. I'm lingering a lot here. Again, I really think I'm going to fly through the dementia screening process, but I wanted you to get a sense of what we've done and how we're trying to promote screening across the state. And just to be clear, we've reached like 50-ish counties. And all that means is we've had some engagement with healthcare teams. Obviously, places that are maybe a little more activated or engaged or diverse in terms of more healthcare systems, we've had more success. So LA, SF, Alameda, San Mateo, San Diego, much more engagement than some rural counties, OC. And I have to say, I grew up on the East Coast, so for me, California is still kind of a blob. So I don't know all the counties, but I am learning. I just want to say too, so if you just take a look, so on our website, dementiacareaware.org, you can get to our training portal. You can look through our catalog, add trainings. The original training we came up with, we would love to revise it, and we are contemplating doing so as our program wraps up, so that our legacy, if you will, is that these trainings are still available and doable. The first one we came up with was 90 minutes don't cringe, please. I'm telling you, it's really good stuff. It flies by, I swear. But so you can get 1.5 credits, and you can take this training and that training and get those credits if that is of interest to you. Oh, sorry. And then we're 1 credit today because this is only an hour, but we also, after getting some feedback from clinics, it would be great if we could just get a lecture on this and then everybody can check it off and we can register everybody as trained. We started offering a 1-hour live version, which is what you're getting today, essentially. And with that, our trainings took off, like tripled our numbers of trainings. That ended up being much more accessible for people, particularly if a clinic was going to organize that for everybody at a regular lunch and learn, for example. So that's actually worked out really well for us, and we have trainers across the state now who can do it, and it's like fabulous. I think it's a fabulous resource for people. We also have a half-hour podcast version, which is also probably the most accessed podcast, but did not, by no means took off like our live trainings did. So I just want to give you a sense of the other trainings we have. So this was our first training, of course, the basics, cognitive health assessment, what is it, how to do it. Then soon after, I know it doesn't seem soon after, but we worked as fast as we could. We launched the team members training. So that means like watching a nurse or a medical assistant and then a nurse, other people on the team doing it, not just everything focused on the primary care provider, because that's how primary care is done a lot now. It's like a lot of other people do components of the assessment, and the supervising or primary provider will review everything and chart and bill. We also have how to do it over the phone or video. So telehealth, tips for adapting it. This is having to do with language or functional or environmental challenges like people experiencing homelessness, different languages, different abilities at baseline, things like that. What do you do after if it's positive? So how to start the diagnostic workup. So this is, I would say, the biggest issue for a lot of providers is like, of course, I can screen people all day. It's not really a big deal, but what am I supposed to do if the person's positive? Advanced care planning, and I'll explain why we actually embedded in the initial screen, assessing the person's care system and support and care partner, not necessarily life partner, because we know that knowing who the caregiver is or people involved in their life is crucial to helping that person at any stage, and so advanced care planning is something we wanted to provide resources on as well as deeper information on connecting with the care partner. And then a little out of order here is something called the Dementia Mini Course, and this is actually really managing dementia. And UCLA Health and the Alzheimer's and Dementia Care team really put that together for us, and it's actually like I think 7 full modules of content with some intro around it, an intro module. So this is sort of our offerings right now. If you go online and sign up for our courses, and all of them have free credits at the moment. Just wanted to give you a sense too, what we also did is create videos about how to do it to show people how to do it. Because when we were looking, and I know when I teach, providers how to do any sort of cognitive testing, it's, you really need more opportunity to see people doing it to get a sense. So we were able to create and then embed some videos on how to do it. So to give that see one, do one, teach one, get the C1 in there for folks and not just have it be like slides and material on a module. Sorry, I was just going to keep going. We also, part of this that I think was maybe a little bit further afield than some of the standard clinical issues is we created a medical legal partnership network with this as well. So the idea was medical legal needs, especially addressed early, are really, really important. How do we, really elevate the importance of addressing the medical legal needs? And a lot of that is incapacity or advanced care planning. Planning for those aspects of dementia and, long-term care and supports and access to benefits, access to caregivers. And so the medical legal partnership, this is just a snapshot from their page. I know it's a little bit, seems a little out of the blue, but basically up and down the state, we have these medical legal partnership network, which right now is really somewhat empowered and better resourced at the moment with this current program to address consults and needs coming from healthcare or the community for medical legal needs related to, cognitive issues. But that's, unlikely to last much longer than our program. So what we have as well is a ton of resources up for people to download and connect people to. And some of the partners, which I think we should all know about anyway, is like Legal Aid at Work, is a really wonderful organization that has been really, really helpful to the program and to the people we're trying to serve throughout. And then other just general information about legal services in California for older adults, issues around Medi-Cal benefits. I mean, this is real rubber meeting the road stuff. And I know all of us are, kind of in different local environments with these resources. Okay. Oh, and then I just wanted to show you, our podcast is called Dementia Care on Air, and has the requisite little podcast microphone. But we now have, actually, maybe we only have 9. We're doing roughly 1 a month, which is about what we can manage at the moment. But we don't tend to go over half an hour for these. We try to keep them really short. Okay, so now this is where, please let me know if you have any questions. I'm seeing that we're doing okay so far. I haven't seen any. But please let me know if you have any, because what I'm going to start talking about now is like what our training is about. And essentially, if you want, you will be, I certainly hope we can count you as trained if you fill out our attendance sheet. And so might as well train you in something you probably already know most everything about. But the issue here is like sort of the approach. So maybe also think for yourself. I certainly meet tons and tons of, appropriately so, I meet tons of skeptics about, is it really necessary to screen for this condition? Is it necessary to detect early? To which my response is a hearty yes, I think it is. And so we wanted to establish early, like why screen for dementia? So one reason is, of course, a highly prevalent condition that we don't detect in roughly half of cases, and that many people die without knowing they have it. And that's just that's, I think, for our medical system should and our standard of care, it should be a little bit alarming that that's kind of the state we're in with dementia. The other factor, of course, and we've all seen these statistics many times, is not only the high prevalence and the high prevalence concentrated in the oldest adults in our society, but of course also that this allows me to make the point that this is going to be a growing issue, very much related to the aging of our overall population. The other thing in Medi-Cal, and I will say this is not necessarily a perfect data set, but Medi-Cal has, in the sense that it doesn't, like Medi-Cal only patients, right, are very young. This could be a very young population. But for folks who are, so generally speaking, it seems like in Medi-Cal beneficiaries overall, there's less dementia. But then there might be, you'd expect in a standard Medicare population, or like, right, we roughly expect the prevalence to be 10% in the general population. So why in the Medi-Cal only? But I think sort of knowing that there's a lot of underdiagnosis, I think it's pretty remarkable that in duals in California, the prevalence, documented prevalence in the chart is 18%. I mean, that's really a lot higher. So anyway, that at least supports that compared to a general population of people who are Medicare only or just general population data that we have, that there's a higher prevalence in older adults who are experiencing poverty. The other thing we point out during our training is that we have racial disparities that, we know that there's a higher lifetime prevalence in adults who identify as African American or Hispanic, but that we know that there's underdetection as well in these populations, so it's really a double whammy. We know that women over their lifetime are more likely to to have a higher risk of dementia. Okay, we have a comment here. Yes, right. Okay, so this is perfect. And we know that definitely if people are diagnosed, they tend to be diagnosed later. And that is even more true for people who identify with minority race or ethnicity. So this was this Medicare study from in California, published now 3 years ago, but basically showing that, first of all, people being diagnosed early, like MCI stage, only 23% of white beneficiaries in Medicare were diagnosed at that stage, which means in general, people aren't being diagnosed, because when we look at people from minoritized backgrounds, it's even fewer are diagnosed in an early stage. Same thing. And it looks even worse when you look at, sort of had they had all the markers of quality care at that stage. So I believe it was imaging, labs, and a referral. That may be a high bar, and it's not necessarily that we're saying all people should have a referral, but it is, when we're looking at aspects of quality of care, it's just really, really low. Again, in everyone, but then it's a further disadvantage to people from who in the study reported being Hispanic, Black, or Asian. So I don't know. To me, that's really motivating. I mean, this is just so much work to do. I think it's a huge and again, very motivating mission across Medi-Cal, across California, across hopefully the country, that we can close some of these gaps, but definitely seems like there's a lot of work to do. But then, so that's sort of like some of the demographic imperatives, some of the equity imperative, but then, are we going to do anything differently? Does it help the individual? And what we bring to the attention of primary care is that, well, knowing if this person has cognitive and functional decline, the hallmarks of dementia, that this would guide your care differently for all their other conditions that, we do perhaps a more accurate job of diagnosing and managing. So I guess one of the points there is, like, if we are not detecting this, if we're not managing this alongside these other conditions, it's not like it's not having an impact. It is, it's a factor, and it's perhaps impairing our ability to have a more appropriate care plan. But then, and that, this might impact the ability to really make sure decisions with the patient, adhere to their treatment plan and medication regimen, and follow up with referrals. And I'm sure we've all, if you're clinical, you've had experiences like this where someone clearly has dementia and they're struggling with self-management and other aspects of their care, but that's kind of not what's being recognized, in the way people are trying to tackle improving that aspect of their care. So the effectiveness of our care really depends on knowing this, especially with such a prevalent and life-altering condition. But then the other point, again, we try to hit on all the things we hope motivate people to care about this condition. But the other thing is, there is actually so much we can do. This is such an active condition, or at least should be. And we know that there's many, many ways to slow progression, improve cognition, improve function. And those things are much more beneficial earlier on in terms of really slowing that trajectory of decline. So we really encourage people to, at the very, at the whiff of a positive cognitive health assessment, we should be implementing a brain health plan. You could say these are good public health interventions overall for any older person, any middle-aged person, really. But clearly even, I would say, more important in somebody who is having some symptoms or positive findings on a cognitive health assessment. And again, we're about to get to the assessment. What we really encourage is something called, with the brain health plan, is addressing hearing and vision. And we point out that hearing is the biggest risk factor for modifiable risk factor for decline, or the most potent one. Reviewing medication. So what are we doing to this person that's affecting their cognition? Reducing anticholinergic burden score and other, known offenders to cognition, like sedatives, sleep medications. Encouraging social and physical activity, and managing blood pressure and diabetes. And these last two, of course, are absolutely part of your standard heart health plan and mental health plan for many folks. So this is, I think for a lot of PCPs, like, maybe even a little bit insulting to remind them to do these things. But I think it gives us more motivation to fold in brain health with heart health and other, and social health, and addressing some of the things that, we're otherwise kind of set up to address as well. Okay, so now I'm going to tell you about the cognitive health assessment. And again, please feel free to continue to add any comments. So we teach that this is an annual screen. It's meant to be a quick check on cognition, function, and support system. The reason we really like to keep people's focus on the fact that dementia is a syndrome comprised of a downward trajectory in cognition and function, not just cognition. And that the support system is also really, really key. But of course, the clinical aspects are cognition and function. That this is just the start of a diagnostic assessment. So I think a lot of people are already like 10 steps ahead when you're talking about screening, and they're worried, what am I supposed to tell them if they have dementia and blah, blah. It's like, you're not quite there yet. You're really just sorting, who you're spending your time on doing these larger assessments into people who are positive on this screening approach, not. So you're really enriching your population for people who are more likely to really have something going on. And it's interesting how this aspect of screening with a mini cog or a MOCA or whatever tool and a functional assessment already puts people into the, sort of diagnostic mindset. Whereas I think with other conditions, we have a clearer understanding of where screening fits in, where, more involved evaluation fits in. And then again, we say this is an opportunity to jumpstart brain health with your patient and really be active and proactive for your patient. And that this doesn't have to be just what we call lovingly the billing provider, the MD, the NP, sort of the diagnostic provider for purposes of billing only. And then we say, well, we break it down into three parts. Part of the reason we did this instead of maintaining cognition function support system as like the structure of the actual assessment is because most people start with a history, and a lot of clinics use like a quick screen and have a question on there. Like, have you noticed changes in your memory? Have you, do you need help with day-to-day tasks? So what do I mean? So we wanted to like use what's there, use what people are doing. They're doing these surveys, like annual health screening surveys for all age groups, and then they have the older adult one. So take a brief history is the first step, and that's usually just a quick question about if they've noticed any changes. So really, really brief. Then the other is using screening tools, validated tools for cognition and function, and this can be with an informant or with the patient. And then ultimately doing a quick check on care partner information. So I'm going to walk through each of these. And then we say, obviously, who do you screen for any condition? The people who are at risk and don't have it already. So you want to only do this in people who don't have a diagnosis and who are 65 and older. Very, 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 very strong arguments that I hear all the time in places considering doing it earlier, because in a lot of Medi-Cal beneficiaries with high sort of exposure to risk factors over a lifetime, or sort of more concentrated exposure, or other social drivers of health, lower educational attainment, maybe lower economic status over a lifetime, things like that. It's definitely, we know that there are a lot of populations at younger ages that are sort of accelerated in terms of developing many geriatric syndromes, including dementia. So, for example, our populations that has a history of incarceration or is experiencing homelessness or has a history of serious substance use disorder, a lot of those things, those populations, if you like, that's what you do, and that clinic is really focused on those folks, you may want to, population-wise, reduce the age and start screening at 50 or 55 or earlier, which I know sounds really young, but definitely is very reasonable in a lot of these populations. Anyway, that was a minor digression. So we teach people to take a brief history. So this could be that annual question that I mentioned, like one example. Do you or others think that you're having trouble remembering things? There's no perfect question. There's no perfect validated question, but these are ones we've seen on a lot of annual surveys that Medi-Cal used to give, as well as the annual wellness visit, a lot of like structured annual wellness visits. These are sort of the questions that are often used. Or I think even more common is the clinician notices something, the standard patient isn't aware or nobody's really reporting. And you're seeing the patient precisely because somebody in the clinic noticed, like, oh my gosh, they could not work with me on this med change when they came for their nurse visit. Like, they really need to see you. So it could be a noticed, like an observed sign or symptom, as well as a report through a question. So that would be one aspect of the assessment. And this is where we take the opportunity, which we've done earlier when we talk about what dementia is and how cognition and decline in cognition isn't just memory. So we do a quick reminder that, like, people could notice their behavior is different. They're, less, positive speech, or something's changing about their language use, or, so we just point out that be aware that signs of dementia can obviously be different. And then very, very sadly, and I'm not making light of this at all, frankly, the fact that more and more celebrities are coming out with non-Alzheimer's type dementias and kind of these like less hallmark symptoms of what even most doctors think of as dementia is a helpful touch point to just reinforce some learning about, well, Bruce Willis presented with aphasia, and well, Robin Williams presented mostly with behavioral symptoms, including sleep disturbance, things like that. Because there's just a little, perhaps more awareness of these issues now. And I really commend those folks sharing that about their lives and doing that. It's, in a way, it's really helpful I think it builds tremendous awareness. Anyway, side note. Okay, so then step 2, you got to use the screening tools. What screening tools? Well, it has to be quick. We are just not able, it's not going to happen to out of the gate say, as a screener, use the MMSE or the MoCA. Of course, those are, if that fits your population, sure. But firstly, those tools do seem to really overcall impairments in very diverse populations, or populations that haven't had a Western education or have had low education, things like that. And just time-wise. So we say you can certainly plan your protocols or choose for yourself something that you administer to the patient for cognition and function, or to a care partner, cognition and function, or mix and match. So one to the patient, one to the informant. So I gave, somebody who came with my patient or knows them a functional activities questionnaire, and then with the patient, I did a mini cog. That would be one example. If you don't know the GP cog, it's really very similar to the mini cog with a couple extra items, and really something going for it, if you will, and why it was included is that you print it out and it's got a part 1 and part 2. And part 1 is the patient, kind of like the mini cog, and part 2 is an informant of function. So kind of like the 88, but a little bit shorter. So that's really why it kind of hits the high points for us. We review what we mean when we say functional change. We review this again, and then also we created a quick and it just adapted. It was already available, of course, like a functional screener. And then pointing out that when you're doing objective tools or these screeners, and you really only have your patient, they didn't come with anybody, which is very, very common. When might you sort of bookmark, oh, I'd really love to follow up with them and get an informant, because we just point out that if the person's completely negative and they are alone, it may be that you're missing something. Whereas if they're screening positive, you're going to do more workup anyway. If that's is just an efficiency issue, you're going to do a next level assessment anyway. And of course, in the diagnostic and next level assessments, you're always trying to get collateral if you can. But it's just a quick point that we make, which I'm sure is mostly doesn't, land. Sorry, having some pop-ups here. And then the issue with the documenting care partner. So really structuring it, many people structure it as, hey, do you have anyone involved or that helps support you around medical appointments or daily activities? Oh, okay. Is there any chance that that person's like, have you done paperwork, makes them a formal healthcare agent or like a durable power of attorney for healthcare? Yes, no, okay. And then just sort of documenting who supports them and can I make sure to have updated contact information in the chart? Great. Then you make a note to follow up on a more sort of robust conversation about their support system at a future appointment. But again, this is almost in some ways, I think it's very practical, but it also just establishes that this is absolutely part and parcel of caring for people with cognitive and functional decline is who's around, who supports them. And I think maybe some of you have been involved in efforts to apply to guide through CMS, but even they acknowledge that if the person doesn't have any support really that's a reliable, consistent, or practical support, that's somebody who's going to take more effort to really help. So it's just like this is just a really practical aspect of care. So what do we tell people? Basically, if there's a positive symptom, so the history, a positive cognitive screen or the positive functional screen, you would consider that positive, start a brain health plan, and plan to do next steps. And of course, we indicate that mostly these are not super urgent or need to be like fully complete workups urgently, really. And unfortunately, it's a little beyond our territory to go into in lots and lots of depth. The next steps does walk through some things, including like, okay, you're now seeing somebody after a positive CHA, maybe it's a couple months later, you're getting a bigger history, definitely look for these red flags because these are things that would make you want to hurry up and do a more aggressive workup sooner. Because of course, we don't want to give the impression that, okay, they had a positive screen, take another 5 years to follow up on it. That's not really what we're saying, but we don't want to imply that, for most people, right, this is not a super urgent thing, but that at the next visit to follow up, you should look for red flags so that if there is, a rapidly progressing process or something that has more neurological features that you may want to, that are unusual, essentially non-Alzheimer's features, you may want to see if there's specialty care or access to that in your area. So a big part of this is that there's this new billing code. So we walk people through, we have a bunch of handouts on our website. Exciting stuff about how to make sure you can bill and take advantage of this new benefit. Annually, if done, the billing provider can get an additional $29 per patient for doing this assessment. So, and Medi-Cal plans and things like that are also, sort of work hand in hand with the Medi-Cal benefit to ensure that, appropriate visits are appropriately compensated. But just an important feature. I think what I'm really trying to point out by taking way too long to talk about this is that, how healthcare really changes and how the delivery of healthcare really changes does sometimes hinge on new benefits, new access to funding. I don't know, in my experience thus far, this particular additional payment has not been like a massive incentive for people to do the screening. But of course, we don't want to, we want to be very clear about how you would walk through the steps of getting this reimbursed. So really interesting question from Annie about additional indicators for specific groups. This is a question in the chat if anybody else wants to take a look as well. So cultural groups that may require lower cutoffs on the screeners or additional collateral information on ADL, IDL, given cultural guardedness and patient reporting. So we definitely, and we did map it out, and I can't recall at the exact moment if it's on the website or not, about like advantages of different tools. So like which ones are available in different languages. My understanding is the mini cog, which seems to be the preferred, and the GP cog are both pretty robustly validated in lower education. So that's like, for example, that's why I wouldn't, especially for a screener, depending on the population, wouldn't really recommend the MOCA or an MMSE or a SLUMS or any of those, because they don't seem to perform as well in different groups. And then, yeah, would love your thoughts more on the functional assessments we recommend. Things like the 88, there's the one they call the FAQ, the second page of the GP cog. Most of them are trying to detect like pretty big changes and things like, and check delta, as opposed to, if somebody never did those things, obviously there's no change if they're not doing it now. So that's not a helpful marker. And we do talk about that somewhat in adapting the CHA, like what if the person is not housed? It really doesn't make sense to ask about a lot of the IADLs, for example. So, and we really emphasize things like, sometimes you can't make a determination in that moment. What you need to do is realize that you're establishing a baseline and you're starting again. This is a screening moment. So you're going to have to do more workup anyway if it's positive, and if you decide there's no clinical change here, nothing's changed about their function once I talk to everybody, even though technically on this survey they look like they're functionally impaired. If it's like the next steps are really the ones where more involved clinical judgment and trajectory really need to be considered. And then how do you think about how to continue to monitor that person year to year? Like, so we sort of talk about how some of this information will help you establish a baseline, even if the baseline that you're seeing is technically not normal based on some cutoffs. It may be, based on the rest of your clinical assessment, you're not worried about an actual decline. So you're just using that information. Like if they're, if they get a 16 on the MOCA and you feel, or the MOCA basic, and you feel comfortable, okay, well, that's their baseline because they're still going to work or nothing's really changed clinically. So we sort of get to some of that. The thing is there aren't any perfect tools and there's not any perfect way to adapt them. The other one is the RUDOS, which I do know a lot of people use and has better sensitivity, especially I believe in lower education. And so would love your thoughts on that. But again, that's just cognition, that's not function, which you brought up is really also, super culturally influenced. I think it's a really good question. We walked through a case with everybody. Since we only have 7 minutes, I'll just kind of, I'll show you the highlights of the case. So it's a woman who comes with her daughter, Anna, and they, go through the question. She says, do you think you're having trouble remembering things? And she noted she's forgotten to pick up her grandson more often because it's sort of like she's losing track of time. So you consider that a positive symptom. You do the screens and she does a GP cog and has a positive, I'm sorry, I didn't go through all the details, but technically it's actually positive or requires more evaluation if you get one thing wrong. And so it's a 9-point scale. So she gets a 7 out of 9. So it's technically a positive cognitive screen. But Anna fills out the informant section and it's a negative functional screen. Then you move on, before we declare this positive or negative, we move on to the support system and asking her So great to meet Anna. Are there ways in which she supports you day to day? We support each other. We go grocery shopping. She helps me keep track of bills. Does she help with coordinating medical care? She comes to appointments to support me, but I make appointments, follow up on my own. Is there anyone else who helps you with any of these things? Not really. Do you have a healthcare agent, someone you've designated to make healthcare decisions for you if you can't speak for yourself? Like, for example, on a document, a lot of people, I'm like, a lot of people have seen this thing. It's called an advance directive. Nope, I haven't done anything like that. May I document honest information as a contact for you? Yes. So then we also talk about how disclosure at every stage, even at a screening, like what am I doing? What information have I learned? How does this help you, not help you? So thank you for taking the time to visit with me today. By the way, at this time, the link for the CE should be live if you want to click on the link that was in the chat earlier, if you do want to get continuing education credits. Thank you for taking the time with me today to review all this. You mentioned, and so what I do is I just explain that I walk people through what I've learned. I'm not trying to make bigger statements than that. So basically, you mentioned you're forgetting to pick up your son. We did that brief test. You just had a couple of places where, you didn't get it perfectly correct. But Anna says, day to day, you're doing fine. No major changes there. But I think, I have some suggestions for your brain health. I also just want to say thank you so much for giving me honest information, and I've made sure it's updated. But because you're having that symptom, the little test result, I think we should just take next steps to evaluate this further to see what could be contributing to your symptoms. I don't think this personally needs to, be a bigger statement about things than that, because as Ms. Ray has pointed out in the chart, or Dr. Ray, is that, like, there's a lot more to learn here, and a lot of context to bring to the situation. And this is an example of documentation in case people want that for their charts. And then we just make a larger point that as you go through the workup and the care plan, focusing on what's going on with their cognition, what's going on with their function, what's going on with their social support, and what do I know about those things? What have I looked into? What have I learned? And how can I support it? Is how you can also just structure a care plan going forward. And so that will hopefully, this is sort of how I'm open to any and all suggestions. This is how I've really thought about it and plan it when I do my clinical work. And so I sort of adhere to this sort of three swim lane kind of approach. And so that's partly why we teach it, or how we got to teach it this way. This is just a QR code, and you should get these in the slides. It's also on our website. Oh, actually, I bet this is going to mess it up with this. But it is our warm line, if you have any interest in that. And this is how you can follow us on LinkedIn if you want to take a picture of the scan. Of the barcode, QR code. Goodness, it's like I'm not living in 2024. Okay, so more. Oh, okay, great. So there's a summary. Thank you. And yeah, we have a couple minutes. Really, really happy to take any further questions.